about land use over there, if they got it. Land use is perfect.
Did you ever talk to Stacy about that?
Wilhelmie. Barry.
Here.
Hart. Here. Izzo.
In here.
McDermott. Winfrey. Here. Grossi, and we also have Mr. Brooks. You have a quorum.
Is there anyone else?
Thank you. Denise, lead us in the pledge, please.
I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning. In the interest of making sure that we have a lot of time in case there's any discussion, I would like a motion to go ahead and go into executive session at this time for discussion of labor negotiations, please.
Second.
Roll call, please.
Barry.
Yes.
Hart.
Yes.
But I'll have it.
This is the updated one. Chair.
Okay, so we went through and we received the renewal from Blue Cross Blue Shield, and we went ahead and again looked at the projection of medical claim history and went through our usual annual process where we project what the upcoming year 2015 budget is going to look like. So we can just jump in. So overall, we're going to go through an executive summary of what the renewal looks like. We'll discuss a few details of the projection for the medical, dental, and vision plans. And then there's some information here that we have that we looked at the wellness program budgets. And then, we've got our life and short-term disability, and then we also include the appendix there, financial ratings. So if we go to page 3 of the executive summary. So overall, when we look at all the groups, the active population, the retirees, and we look at your medical plan, your dental plans, and your vision plans. For 2015, we're looking at about a 3.5% decrease in the projected spend, which actually amounts to about 1.4 million. The breakout is, so this is basically being driven by favorable experience. And so the breakout is when we look at just the active employees only, there's about a 1.2% decrease in your projected 2015 spend. And, that's about 370K. The PPO is increasing about 2%, and the HMO plan is decreasing about 7.6%. For the retirees, we're seeing about a 17% decrease. That's amounting to about 1.1 million. The PPO plans, including both the pre and post 65 and the RX only plan, we're seeing a 16% decrease, whereas the HMO plan is about a 22% decrease. For the dental plans, we're seeing a slight decrease. It's a 0.7% decrease, and that amounts to about 13K. The active folks, we're seeing a 3% decrease, whereas the retirees, that's a 26.6% increase. Vision plans, we are under rate guarantee through the end of 2013, so no changes to the fees there. And we got the life and STD renewal in, and Dearborn is holding the rates flat with a 2-year rate guarantee.
So Brian, with the retiree rate increases, is that being driven a lot because a lot of people are migrating out of the plan and into Medicare supplement?
Yeah, you've got your retiree population is actually decreasing, and then some of it also is still being driven by some favorable overall experience. So just some details on the actual renewals. We base the projections on the county's actual experience, and we use 24 months of experience. For these projections, we're using July 2012 through June of 2014. And what we do is we break it up into two 12-month periods. We give the most recent 12 months, that's July 2013 through June 2014, we give it a greater weighting, which is about 67%, and then 33% for the prior year. And basically, the reason we kind of do that is to smooth out, give the projection more credibility and smooth out volatility year over year. There were about 6 large claims that exceeded the 190K stop loss on the PPO side. The total was about 1.6 million. On the HMO side, there was about 2 large claims, and the total for those were about 340K. So once we pull out the claims in excess of the stop loss on both the PPO side and the HMO side, on a per member per month basis, we're seeing a 6.1% increase in the PPO and 0.4% increase on the HMO. Some assumptions that go into the claim projection. Trend this year, we're looking at, we are recommending, and we used a 6.6% trend for the PPO, 6.3% for the HMO. We held the dental trend of 4%, which is similar to last year. Now, we're basing our trend on the Aaron Hewitt internal trend guidance, which uses national data, but then we do adjust the trends to custom them to the actual county's plan designs. For the retirees, we used a 7.9% trend for the PPO and a 6.4% HMO. The retiree drug trend was slightly different from the medical trend, which is at 7.3%, and they had a similar 4% trend for dental. The ACA fees, the transitional reinsurance fee for 2015, that's coming down to $44 per member per year. It's currently at $63. And we included the PCORI fees in the projections, and the claims projection, we do include a 2.5% margin. Any questions so far? So the fixed costs. So Blue Cross came in on the PPO, actually both the PPO and the HMO. Blue Cross was asking for about a 4.3% increase in the admin fees. On the PPO side, we were able to negotiate that down a little bit, so we ended up with a 3.75% increase. And what that means is that currently you're paying $52.23 per employee per month. For 2015, that's going to be $54.19 per employee per month on the PPO side. The prescription drug rebates are actually increasing as well, so that helps. It was previously $17.02. For 2015, it's going to be $17.17 on the PPO side. Stop loss actually increased close to just under what we were initially anticipating. It's at now 19.93 for the PPO. And one of the reasons for that increase is at 190K for the PPO and 100K for the HMO, and I'll discuss the HMO, those are actually, the stop loss levels are actually lower than what Blue Cross would typically recommend. And we will go through some of the Blue Cross recommendations on stop loss. On the HMO side, there was a similar 4.3% initial recommended increase in the admin fees by Blue Cross. We were able to bring that down to 3.76%. So you're moving from $41.80 to $43.58 per employee per month. The rebates for the HMO actually decreased. So for the HMO, we're going from $9.92 per employee per month to $9.71 per employee per month. Stop loss increased at 8.2%. To $78.47 per employee per month. But then the good news is the Blue Cross capitations actually are decreasing 0.8% per employee per month. So that was actually some good news, because typically don't see capitation rates actually decreasing. Then just a quick reminder on some ACA requirements for 2015, and the county already has adjusted the eligibility to address this, whereby all employees working 30 hours or more need to be provided with coverage. So on 7, we do just summarize the fees, and so just high level, some of the items that we talked about. Your admin fees for the PPO are $54.19, which is 3.7% increase from current. The HMO is at $43.37, actually not $43.58, $43.37 final. So your total fees for the total fees cost, including your ACA transitional reinsurance and your PCORI for the PPO, is coming in at $115 actually 53 cents, which is an 8% increase overall. And for the PPO, it's coming in at $451.47, which includes capitations in there of about $408. So your HMO fees actually total overall are remaining flat. So over to the stop loss. So currently the PPO is at 190K and the HMO is at 100K. And so we went ahead and asked Blue Cross to quote and price on some optional stop loss levels. And they also provided their recommendations. So for the PPO, we asked them to show us what 210 would look like, 230, and 250K. Their recommendation for the PPO is actually at 230K. And for the HMO, their recommended stop loss level is at 115K. So the estimated saving with just fees alone for the stop loss at their recommended level would be a savings of 145K for the for the PPO, and for the HMO it's actually an 81 to 82K savings from their recommended loss. Now the thing about stop loss is it comes down to what the county's tolerance is for the risk exposure, because stop loss typically it fluctuates. So you may see that these are savings related to just the fees alone, but depending on how good or bad the actual large claim exposure is, you may not actually see any savings really, depending on if you have a really bad year. What we did do is we looked at what the projected 2015 costs would look like under the Blue Cross Blue Shield recommended levels. And the total savings really, you would see an additional 76K in additional exposure from where you are today. And so that would eat into the savings that they projected. So initially, if you look at the 145 and the 81K, that's about 260K total. Then you'd have about 76K in additional exposure from increasing those levels. So the actual savings in total come down to about 185K.
That's based on projections?
Yes,
How
that's
is
based on the
historically
2015 projection.
Right, how does it look historically?
Yes, so that's looking at the historical data through June. And so, like, for example, in the most recent period, we had about 6 claims in excess of, on the PPO side, 6 claims in excess of the 190K. The total was about 1.6 million. The HMO only had 2 claims, and the total was about 344.
So 6 times the difference would be 40,000 roughly?
Yeah.
Or some of the claims didn't actually go all the way to the 230?
No. Some of the claims didn't.
Well, I'm
go
just
to
looking at
230.
the premium savings to go all the way to 250. What the additional exposure is only 20,000 per claim.
Yeah, going from the 190 to the 250.
Yeah.
Yeah, going from the 190 to the 250. The additional
from there,
is
230 at?
Yeah, the 235, your additional exposure
Only
is
15
45
per claim.
Well, it's 45 additional. So for any claim any claim that was above the 235 today, you'd be picking up an additional 45K on that.
It's going from 235 to 250, right?
No, it's going from, so the current stop loss level is 190.
Yeah, I'm just looking at the difference between, I guess the premium savings isn't that high. Premium-
Yeah.
Yeah.
The savings and fees isn't that high.
No,
We've had bad years.
it's just numbers of claims, it's
Yeah.
not, yeah.
I know, but
I don't know, what's the rest of people think, we should increase it? I just was thinking, well, you didn't do the projections based on going up to 250.
No,
No.
no, the projections are as everything as is.
All right, that's fine. Fine, sorry.
But in terms of going up to 250, our experience is that we haven't had that many claims at that higher level. Is that true?
Right. But you, and again, that's just because, you've had favorable experience. You could have, stop loss is.
I don't know what that is. It's, okay, never mind.
I don't know, I would,
How they
personal opinion
claims.
would be to go with your recommendation at this point in time.
So what would Ann on that?
Well, our general thought was, we feel the savings currently as due process priced is not really enough to necessarily move. We were going to try and see if we can have them give more aggressive quotes, such that some of these savings in premium do actually make sense. But yeah, right now, our collective recommendation was, unless there's a compelling reason that the county wants to move, we don't see that the savings necessarily make sense as is.
So we'll hold the plan on that, and unless we get a more aggressive quote,
Right.
loss, then we can bring it back to the committee on the stop loss piece.
So that's both the HMO and PPO.
And PPO. Correct. So on page 9, we do just give just a summary of the plan design changes that will be in effect in 2015. So these are all designs that we're all familiar with. We just thought we'd just kind of summarize them and revisit them. So there's no new information on this particular slide.
This just shows, based upon our contract negotiations, how we did slightly increase the deductibles on pockets and emergency co-pays, and for the HMO, the office visits, emergency as well.
You can see that they're all slight increases, and they're very much so in line with benchmarking in terms of counties and communities that are business.
On slide 10, we just now throw in the numbers, so that's pretty much gone over, so it's present them in a chart here. You can see all the way at the bottom, so with inclusive, the PPO, RX only, the dental plan, the vision plan, is a 3.5% decrease in the budgeted 2015 costs, which is a 1.4 million. So generally, all plans and groups, we're seeing decreases for 2015 except the active PPO plan, which is going to have a 2% increase, which amounts to about $430K in total spent for 2015. So overall, we're projecting basically 38.6 million versus the current premium we're projecting at 39.9.
Do you have anything in your projections that's saying why the pre-65 retirees is going down so much?
I think, yeah, they're having favorable experience, and we've also seen a decrease in enrollment in that group.
That there's a decrease in, so that meaning spouses and things are falling off?
Yeah.
Okay. That's what we kind of figured when the rates went up. So when we re-rate them, the rate should go down this year?
They are going down,
Okay.
the retirees, yeah.
Okay, so that's later in the slide.
Yeah, I want to make sure that my memory serves me correctly. Those deductibles are going to slightly go up next year, but they do include the RX prescription co-pays will be included in those amounts, right?
Next year.
So it'll be more favorable.
It could be.
It could be, but those deductibles will include prescription, which was not the case. Am I remembering right?
Next year.
So that increase, I mean, for people that have prescriptions, it might be favorable.
So this 50-plus group that's falling off, is it because these rates are too high, they're going on other plans?
Yes.
Or is it-
Mostly the post 65 retirees, the cost was so prohibitive, especially with the prescription drug program, that they can get a Medicare supplement and a prescription supplement, Part B, much cheaper than staying on the county plan.
Can't wait till 65. All right, thank you.
Other questions?
So the next two slides, we won't really go into detail, but we basically provide the kind of high-level background into how we come up with the projected cost. So just, if we're looking at the actors, this is something you can go through and, it kind of walks you through how we come up with the projected cost based off of using historical experience and here, we've got the weighting and then, the application of the trend assumptions. So we won't necessarily go into these in any detail here.
The print is small, print.
Go like that.
Yeah.
So going over to slide 13, here's now where we present a first look at the funding rates. And we're presenting these on a 4-tier basis for both the HMO and the PPO. So the left side of the page shows the PPO rates, the right side shows the HMO. Then top to bottom, we have the actives, pre-65 retirees, post-65 retirees, and then right at the bottom is just the RX only post-65 retiree plan. So you can see, the PPO top left corner, we got the 2% increase in the PPO rates, whereas the HMO, we got the 7.6% decrease. And, likewise, to answer your question, the retirees here, you can see the decrease in the retiree rates at 16% for the PPO and 22% for the HMO. So yes, and so we present these on a 4-tier basis. These tie back to the summary costs. So right at the bottom of each of these, you can see what the projected costs for each of the plans are for both 2014 and 2015. So for example, looking at the top left, which is the active PPO, we're projecting 21.9 million in spend for that group. Any questions on the premium rates and budget rates?
I guess the only question I have is then the 16.1% decrease is in the total group, so you're just equally applying that?
For the retirees only, yes.
Well, the rate was equally applied to the active too, with 2% increase. So you didn't redo
Oh, you mean on the tier basis?
Yeah, the tier basis. You didn't redo
no.
the actuarially with tier rates.
No, so, because we look at, when we come up with what the current funding rate is, we're looking at what your distribution is already. So it factors in any changes in distribution anyways.
I guess that makes sense. You just figured it applies evenly
Right.
throughout the tiers.
Yeah, and we never redistribute by tiers, actual experience, because the groups get really small and can be very volatile. So that's why in the industry, we always do it by plan.
Yeah, for the whole section, so to speak.
Right.
Yeah.
And then on slide 14, we show the dental. So here you can see again, we show actives at the top, then pre-65 retirees in the middle, and post-65 retirees at the bottom. So you can see the 3.1% increase to the active costs, and 25.9 to the pre-65, and 26.6 to the post-65 retirees. Okay. So slide 15, I guess this is the fun stuff now. So we look at slide 15 looks at the contributions for, these are for the non-union and the absolute folks that settled for a 4-tier basis and a percent of pay. Percent of premium. So on the left side we show the PPO, and on the right side we have the HMO rates. So the first thing, right at the top, you'll notice the salary bands. And these are changing from what we currently have, because we currently at 30K, then 30 to 50K. And so what we did there was, as per the agreement, is we're adjusting those salary bands based on the average CPI, as of the end of June 2015. So those now go up by 1.6%. All those salary bands get scaled up by 1.6%. So we still have the 4 salary bands. Right at the top we show the enrollment for the groups, for the folks in this group. And below that we have the funding rates, which are just similar to what we saw 2 slides ago. And then the bottom piece, or rather the second from the bottom, shows what those 2015 contributions will look like. And those are set to ensure that on an aggregate basis, the county is collecting 9% of premium from the enrolled folks.
And that's an increase from the current
8%, yes.
What's the increase there? How much is the increase? What's that?
And what an employee is actually paying.
Right.
It comes out to about 18%, but it's not because of the rate. So there was a rate cap that was negotiated, and saying that the premiums, the underlying premiums, could not increase by more than 12% on which this was applied. But then, so that, like for instance, the PPO was a +2, so that was well below that 12% cap, and then the 9% is applied instead of 8, and that's really what's driving the change.
No, I see what you're talking about. I know.
Yeah.
See, that's what okay.
Any questions on this page? The next slide over, we show the dental rates again for the same group, the non-union and the absolute folks, 4-tier basis, and over the 4 salary bands, which are adjusted for the 1.6% CPI. Same thing with this group is the target was to have the county collect 9% of aggregate premium from this group, which is an increase from current, which is 8%. Any questions on that side? Then on the following slide, we show the retiree rates, the retiree contribution rates. And so on the left-hand side, we show the 2014 rates, and on the right-hand side, we show the 2015 rates. For retirees, as you know, the retirees alone, they don't pay any contributions for the plan, but they do pay the full contribution for any covered spouses or dependent children. And so that's no change from what we're seeing today. If there are no questions, we can move over to the excise tax.
Before you do that, I just want to say that slides 13 through 17 actually cover the next item on the agenda, which is the rates.
Okay, so just a quick overview and reminder of the excise tax. So in 2018, plan sponsors are gonna be charged a 40% tax on, excess, employee healthcare benefits. The excess benefits really are defined by, any benefits that exceed a certain, thresholds that are being set by, under the ACA. And, your covered employees are, all those employees, the benefits that are included are, all benefits, including employee contributions, to cafeteria plans. The thresholds are, as of 2018, there'll be $10.50 for employee-only coverage, and then every other coverage other than employee-only is considered family coverage, and the threshold for that will be $27.50. So any plan costs in excess of that get hit with the 40% tax, and those thresholds are actually going to be indexed on a year-over-year basis, and currently, the guidance is it's probably going to be indexed by about the CPI. Your qualified retirees, if you look at the darker box, what that really refers to is your pre-65 folks. So they actually fall under that qualified retiree group because they're more high-cost participants. Now, the one thing I do want to point out is all estimates that we've currently been doing today, there hasn't been that much guidance. We do know that probably once we get closer to 2018, we're going to see more guidance on how this excise tax is going to be calculated. So, for example, one thing that we're still not sure about is how they're actually going to estimate what the cost of the plan is. So to date, what basically we're doing and what we've done to estimate the counties is we're basing it off of our budgeted costs. If you're a fully insured plan, what folks are generally doing is using the fully insured premiums. But we're pretty sure that closer to 2018, they're probably going to come up with some kind of standardized method to estimate the plan cost, because these plan costs can actually be massaged to come up with different results.
Yeah.
Particularly in a self-insured environment where the claims projection could be played with, essentially.
So when we go over to slide 19, we have a summary of our estimated excise tax calculation. If you look at the fourth column from the right, we show what we're estimating as the excise tax for 2018. Now you will immediately notice that the three groups that we are projecting to hit in 2018 are the active PPO folks, the pre-65 PPO folks, which is a much bigger number, that's the $609 rate that's estimated in excise tax for 2018, and then the pre-65 HMO folks. We anticipate that the active HMO and the pre-65 retirees are going to hit those thresholds further down in about 2022 and beyond. So overall, we're estimating for 2018 an excise tax liability of $847K. Now, the one thing that I always like to point out is when we look at the next column over, that shows what we're projecting to be the present value of the next 10 years from 2018. And so you can look at the 847, compare that to the 39 million in current spend, and it may not look as such a big number in comparison to today's current plan cost. But when you look at certainly the present value, because your plan costs are going up by trend, the thresholds are only going up by the CPI, which is a much lower number. So your gap is exponentially increasing. So you can see that 847 in the first year, 10 years out, we're actually projecting 31 million in excise tax liability. So that's when you start seeing it. This is something that we probably want to definitely start putting into place some actionable items that will prevent or lower that increase in the liability.
So there's a couple of things we're currently doing. Of course, the wellness program, which is really meant to help improve the health and contain costs long term. We know from a health improvements perspective that is not a one-year hit. That's not a quick savings by any stretch. It takes years for someone to get unhealthy. It takes years for someone to get healthy. And even then, they can't necessarily erase the years of bad living So, you know, the program, we're gonna talk about that in a little bit next. It's really gotten off to a good start. So that's one thing we need to do, but, and then of course the renewal coming in where it did is really helping as well. So, you know, the more you can beat trend, with these renewals, the better this picture's gonna look long term, so.
Can you point to any one or two indicators that our plan is, in our plan is causing us to be in the excise tax and the PPO? Where's the rich part of it?
Really, there's two elements that are key drivers. It's demographics. As people are older, they use more services. We all start to kind of break down a little.
So the age of our population?
Age of the population is definitely a contributing factor. I think you guys have an average age close to 48 or 49, so that's significant, right? And then
Right there, Dan.
just plan design in general, right? We know that a lot of employers that are facing excise tax are starting to think about consumer-driven plans, getting employees to voluntarily move to lower cost options. You know, one of the things that doesn't come into this equation is contributions, right? So right now, you guys have a lot of dependents on the plan. You have a very nice plan. It's a reasonable cost plan compared to other employers. So you have a lot of dependents to take your plan. Those kinds of things are contributing factors to your cost, right? The more people you cover, the more you pay. So those are things that, you know, you're not going to be able to address in the short term, but they definitely, especially if excise tax doesn't look to be going away. You know, there's still time for that to change, but so far, you know, they haven't really repealed any piece of this law. They've delayed a few things. And the only thing they've actually done away with was long-term care, because they figured out financially it couldn't work. There's been press, like there are people that have come out, analysts, some universities have come out and taken positions on how they think this tax will change the future of employer-provided healthcare. There was one in an HR magazine just a week ago that basically some analysts thought that this would be the end of employer-provided healthcare. Because as employers today, they can't afford to offer it. So it's a big debate, we don't know.
You said that employee contributions do not
They don't
play.
play into this.
So if you were to, just thinking ahead for the next negotiation, if you were to shift to co-pays and higher deductibles rather than premium base?
That will help, but you know, there's a balance point, right? It takes a lot of change to save money.
Yeah.
As you guys saw when we did that, you know, you change a copay and it saves 0.5%, so it's not enough. But some of the things other employers are starting to do is, as I mentioned, put in lower cost options and then significantly change the contribution to encourage employees to take that additional risk. Those kinds of
Well, that's what I was
strategies.
getting at. So by increasing risk, by higher co-pays or by lower benefits would be the way to go.
Yeah, and that's, you know, that's not necessarily a one-year
No.
proposition. A
But
lot
it's
of
something
plans
to
are
start
looking at
thinking about.
multi-year.
We have 3 years for the next negotiations. So.
And the challenge that is specific to the county is your contribution structure is so much better than the rest of the world. An average for-profit employer's cost share is probably in the neighborhood of 20 to 30% of the cost. So, you know, what's meaningful to that employer group, when I say I'm going to give you something that's almost free for consumer-driven, to take out consumer-driven, for you guys, your costs, you're not charging so much now. So it's not, the carrot isn't enough to make someone necessarily take that risk. That's the special challenge that you're going to have. So again, just as Brian said, this thing, we don't have any additional guidance after the law was written. We've interpreted it based on what was written initially, but there's been no new guidance on this. And as we've seen with HHS and the IRS, et cetera, they are delivering this information kind of as needed basis. So we're just now getting, for instance, reporting guidance that employers are going to have to deliver in January 2016. And so, you know, I expect that we're not going to have any excise tax guidance until probably 2016 or 2017 at the earliest.
What is this?
Page 21 starts the section on discussing the wellness budget. So this first page, we have it broken out from plan costs, and then the bottom half of the page would be the premiums and charges that are incurred based on participation. So for this first section, we illustrate the estimated participation, which is an increased 5% over the current 2014, which would bring us to around 1616, costing $40 per screening, and then that 64,000 is the total. So going across the different line items, we have the line item search for costs of the plans, the on-site screening, LabCorp facilities, physician forms, and then the additional costs incurred through website resources, the $100 gift card administration, etc. So you'll see that the total projected wellness plan cost is around $304,000 for the upcoming plan year. And this is assuming a 5% increase over the 2014 participation. So we're assuming that 5% of those that got hit with a surcharge this year are going to participate again next year. The estimated premium surcharges we have listed in the bottom half, assuming 80% participation from employees and 70% participation from spouses. This is high participation, but as we said, you guys did have great turnout this year. There's currently the surcharge is $50 for an employee that doesn't participate and $25 for a spouse, but that is increasing to $50 for an employee, $50 for a spouse. So that's that third from the bottom line. And the total estimated surcharges combined would be around $333,000. This was the conservative approach. The more aggressive approach on the next page, again, around the 304 total costs based on the same 5% increased participation, but we do see that increased surcharges up to $413,000 based on the surcharges that would be for 74% participation for an employee and 74% participation for a spouse.
Currently, we're at about 74% participation, but we still have until Friday to complete.
Well, the 74 is actually based on those that did the biometric, so we developed this, we kind of assumed that they're gonna follow through and complete the last three steps in order to avoid the surcharge on the premium. So, you know, I think we're at 60, last week we were at 65% of those who've done the biometric screening had actually completed the last two steps, which was do your health risk assessment and do put your physician's name in the Neanderthal site. So I know there's a push to get people to finish up and avoid these surcharges. So we've actually assumed that they will do it and avoid it because I think doing the blood work shows an intent.
And so we're actually going to send out a postcard campaign this week to those individuals who did do their biometric that may not have done their HRQ, to get them a reminder and get them what they need to do.
On page 23 are some of these stats that both Bruce and Kathy just illustrated that right now at a total of 3,007 employees and spouses were eligible, and we had 1,933 employees and 1074 spouses. That number with 74% participation rate, which is definitely pretty high for a first year loans program. So that was a great result.
Yeah, and I think when we first started working with Wellbation, they actually estimated the first year, which we kind of didn't agree with, but they estimated 40% participation. So this is really a fabulous first year result, and especially some of the communication challenges. You know, not everybody in Bedford County has email, so I know Regina said she's kept a log of 37 different communications that have gone out the last few months to get people to get in there and do those activities. And I mean, I just have to say I'm impressed with how you guys have rolled this thing out and the effort that obviously everybody in the committee and the HR team and so on have been involved in. It's very good.
Yeah, and that 74% participation is based on those who participated in the biometric screening. In order to not incur that surcharge, there actually are 2 additional steps that they need to participate in. And of the 74% that participated, only 60% have done all 3 steps. So that goes back to Regina's communications and really pushing that there are a few outstanding details that need to be taken care of before some of the surcharges start to hit in September. I think we hit on most of the facts that we've seen throughout this year. Just to touch on, the screenings will likely be moved to the April-May timeframe next year.
Then the last section is the basic wage agency and STD with Dearborn. All of these coverages were up for renewal this year. Dearborn did agree to continue the rates. The experience was not so great in the short-term disability. There's been a number of disabilities, higher incidence than they expected. And the term life's been running well, so overall they've decided to hold the rates. On all of these are all the county paid benefits here on page 25, and then on page 26 you'll see the employee paid rates for the voluntary coverages. And again, this is no change to the rates, and this is a 2-year rate guarantee. So while you can terminate, prior to the end of that 2 years, it is the rates will not change in that 2 years.
I have one question for the life insurance piece. Is it affordable if a person was to leave?
I cannot recall. I don't know if you guys know if there's portability built into the voluntary.
There is not portability into the voluntary plan.
Yeah, many of these will have conversion, but conversion is quite expensive, so most people don't convert unless they have a terminal illness.
Right, it does have a conversion provision, but not a portability.
And then the last section is really just to give you an update on the financial stability of the carriers that you are using. So Dearborn, of course, is your life and disability carrier, or life and short-term disability administrator. And then Healthcare Service Corp is Blue Cross Blue Shield of Illinois. Both of them are on our authorized list, and they do have carrier financial ratings that meet our minimum standards. And of course, that's no guarantee, but they appear from everything you can see.
Very good. Any other questions?
We have 2 resolutions.
Right. So what we need then is an approval of the renewal of the comprehensive group medical plan. Matthew? Need a motion? Move. Second. All in favor? Aye. And then number 2 is approval of the active COBRA and retiree group insurance premium rate equivalents.
Second.
All in favor? Aye. That is it, thank you, appreciate it very much. We have no other business this morning, I have no announcements, we have covered executive session, and I need a motion to adjourn. So, all in favor?
Yes.
Thanks, guys.
To get permission from 8 neighbors.
Okay. And you live in a one block area, you said?
Well, we live on a corner,
Uh-huh.
and one of them is only 1 street, and the other one is, I think, 3 streets, 3
Okay.
short blocks.
All right. And is there anybody objecting to what you're
Absolutely
proposing?
not. Actually, I was making a joke, saying I wanted to bring half my neighbors here
Mhm.
but I don't think they would have done it good, but I don't know. They'd have to take the day off work too.
And to the best of your knowledge, there's absolutely nobody
Absolutely
opposed to it?
nobody. Everybody's asking about it, what's going on, and they're like, that'd be fine. None of them have any objections, not a one.
Thank you.
Okay. I'll ask, is there anybody in the audience that objects to this change? No. Okay. We have a motion to approve. Motion? Second? This was a split vote on PCC, so let's have a roll call.
This motion just to allow her to do it.
Right.
Vandermeer,
Aye.
Bible,
Yes.
Frisellon,
Yes. Okay, motion carries. Let's go to the county board then next week.
Do I have to go there too?
You know, might be a good idea, but
Okay, I need information on it, thank you.
The county board is third Thursday at 9:30.
9:30 in the morning again?
It's in this room as well.
The same room?
Yes.
So next Thursday, the,
Right.
what is the date?
Third Thursday of the month.
Third Thursday of the month, 9:30 here again. And since you guys approved, what is the purpose of that meeting then?
well, we recommend it to the county board, and then they have to vote on it also.
All right, very good. Thank you. So I'll bring my paperwork. Do you want this, Ben?
You can keep it, that's fine
Okay,
if you like.
thank you.
Okay, next item is text amendment concerning owner-occupied dwelling units. David?
Yes, as directed by the committee, we held a public hearing at the last planning and zoning commission for a text amendment to the zoning ordinance regarding owner-occupied accessory dwelling units. The text amendment that was considered a public hearing is on the third page of the memorandum that's in your package or on your iPads. The change that was a public hearing was under residential household living. Household living was owner-occupied accessory dwelling unit, was identified in the use table